Good afternoon, and I know people are still coming in, so feel free to continue to get food. My name is Jose David Saldivar, and I'm the director of CCSRE, Center for Comparative Studies in Race and Ethnicity, and I'm also a professor in the Department of Comparative Literature. So I'm really delighted to welcome all of you to our Winter Quarter Week 3 faculty seminars today, featuring Dr. Fernando Mendoza, Professor of Pediatrics from the School of Medicine and Lucille Packard Children's Hospital. I just wanted to welcome him in more personal ways because I've known Dr. Mendoza for many, many years. I won't say how many, but Laura told me this morning how many years. He is an internationally recognized scholar in the field of maternal and child public health, among other field imaginaries. And he served as a fabulous mentor for scores of undergraduates, medical students, and faculty. And one of those Stanford medical students is my wife, Dr. Laura Saldivar, who worked with Fernando. She's working today, so she couldn't be here, but she really wanted to be here, and I wish you all the best. So I just wanted to acknowledge that, all the great work that Dr. Mendoza has done. When I was a postdoc many years ago, we were together at the Center for the Chicano Research, where I was able to do some work on my second book. Now, to give to continue the welcoming, I'd like to ask Professor Prudence Carter, Director of IRC3, to come forward and say some words about Dr. Mendoza and his talk today. Thank you.
Good afternoon, everyone. Ooh, it's so pretty outside. It's sunny. Can we do this a little rose here? Good afternoon, everyone. Yeah, it's good to see you. Thank you for coming here today. I'm really happy to introduce our speaker today for the first talk in our winter series, for the IRC3 Faculty Seminar Series. Before I introduce him more in depth, I just want to draw your attention to a couple of things. First of all, we have two other talks that are upcoming this quarter, one on February 27th with Professor Ann Morning from New York University. Her talk is entitled Race and Raza, Concepts of Difference in the United States and Italy. And then on March 13th, Professor Ari Kelman, who's the Jim Joseph Chair in Education and Jewish Studies, he'll be talking about learning to be Jewish. So those are the two other talks. And then I also draw your attention to February 6th, where we have our kind of afternoon chautauquas, our kind of book club on campus, where you get a free book and over wine and cheese and other hors d'oeuvres. We actually get to engage with each other. You really should do this if you haven't done it. It's a lot of fun, and it's so rare that we get to engage with one another, not in the classroom or in a formal setting, but really to kind of talk. And so Professor Richard Thomason Ford is the feature for that day, and we'll be discussing his book, Rights Gone Wrong, How Law Corrupts the Struggle for Equality. So if you have the time, that's from 4 to 6 p.m., on the 6th of February. If we may have seen it and you're interested, let us know. You can contact we actually have an RSVP list, Heidi Lopez. We'll get you a copy of the book and join us. Okay, that's it for kind of general housekeeping. It's really my pleasure to introduce Dr. Fernando Mendoza, who is a professor of pediatrics and the Associate Dean of Minority Advising and Programs at the Stanford School of Medicine. I mean, as I read his vita and read his bio, I also realized that he's just a Stanford man. Dr. Mendoza has received his medical degree from Stanford, his postdoctoral training at Stanford and Harvard University. As many of you know, he is really renowned for the work that he does in the area of health, workforce diversity. In addition to just incredibly deep and particular research interests that are focused on the health disparities among poor and immigrant children, particularly Latino children. He has published studies on their growth, issues, health status, healthcare access, and factors affecting early childhood development. I am really, really into these issues today, so I am excited to hear your talk, Dr. Mendoza. This research has been used to inform pediatric workforce policy through the American Academic Pediatric Association, the American Pediatric Association, and the Federation of Pediatric Organizations. It's my extreme pleasure and honor to be able to introduce Dr. Mendoza today, who will be talking to us about immigrant Latino children, their health and well-being, and why it matters to California and the nation. Please join me in welcoming him.
Well, thank you for that marvelous presentation by both of you. I wish my mother was here. So my intent over the next 50 minutes or plus is to really give you an idea about the situation that is facing Latino children in California and the nation, and why we all need to be concerned. You know, when you think about immigrants, at least when I grew up in the 1950s, we had this picture of the idea that this country offered tremendous opportunities for any child that wanted to come here. And they could do whatever they wanted, they would be successful. But, you know, certainly you all probably know well that that wasn't true. The reality was that basically some children had those potentials, others did not. Others fell into the ghettos and the communities that were ethnic in the East Coast, and you could talk to their families, and they would tell you this was not an easy life to be in America. Now, my only disclosure is I come from an immigrant family. That's my grandfather, Al. and you know, you don't really hear about what happened on this side of the country in immigrant. But my grandfather was in the Mexican Revolution, and after that, he left because the situation wasn't great. And like many Mexicans after that war, they came to work both in the fields and the railroads. Here's actually my little guy in the white thing. There's my father. And he and his family worked on the railroads and then settled down as farm workers in Santa Barbara, in that area, and then eventually in Alvista. So I was born in San Jose and grew up in a place called Gardner, which is now a community in San Jose, a very poor Latino community. So I have this personal relationship with the idea, what does it mean to be an immigrant? And I think from that standpoint, I have sort of tried to think about what are the appropriate questions we should be asking. What's the big picture? So part of that big picture for me was that I grew up in San Jose, actually in a place where both ends of my street had orchards. You know, Santa Clara County was the fruit capital of the world. You could grow everything. It was all agriculture. And this was in the 1950s, so I had that experience of what that was like. Now, it's really rare to go from that to something that is quite dramatic, and we've all done that, right? Silicon Valley. So when I grew up, there was probably a handful of ethnic groups. Now Silicon Valley. The entering kindergarten class speaks 100 different dialects. 100 different dialects. That means 100 different places in the world they come from. In Los Angeles, they're talking about 120, 140 different dialects. There is no place in the world that has that diversity now or any time in the past. So how do we, as a society, meet the needs of the future generations, the human capital? And that really is something that has happened in this country over the last few decades. You can see in the blue, that is the amount of immigration from Europe. And over the last 20, 30 years, after the passage of the 1965 Immigration Act, what we have is really immigrants from Europe becoming a very small proportion, and immigrants from Latin America and Asia basically becoming almost 80% of all the immigrants to this country. And we can see from around the world, they're coming from all over, but particularly those areas that are in the dark areas, from Latin America and from Asia. So what does this mean? Well, there have been a lot of people that start to look at this issue, and one of those is Pascal at the Pew Center. And what they've identified is, in fact, this is changing the character of children in this country. And it's changing by the fact that many children now live in what's called an immigrant family, and I'll define that in a minute. And at this point, it's 1 in 4 children. Think about that. One out of every 4 children in the country lives with a parent that's an immigrant. And for Hispanics, that's almost 60% of the population. For Asian, it's almost 80%. And in fact, if you look at the amount of child growth, the population increase since 1990, 75% of that growth has been from these populations. Moreover, the estimate now is in 2050, or even before that, 1 out of every 3 children will live in an immigrant family, whether you're in California or Kansas. I was just in Oklahoma, it's even there. So by definition, this is what we use. Children in immigrant families, a child living in a family for one or both parents are foreign-born, either documented or undocumented. Those families also have not just first-generation, kids that were born outside, but more commonly second-generation, kids born here to immigrant parents. And most of these families are not fluent in English, and they have different cultures. So think about that. 1 out of every 3 child in the future will look like that. Where did it come from? You can look at this with the recent assessment, and basically Mexico is the biggest one. But if you calculate Mexico, Central America, Latin America, you see almost 60% of all the immigrants come from Spanish-speaking countries. The others from Asian countries, and then a small handful from others. So if we're talking about children in immigrant families, the great majority are going to be either Latino or Asian. And as I said, they increased the growth of our population. The matter of fact is, if they weren't in this country, we would have a negative child growth. This is the growth rates for Latinos from Mexico, Latin America, Asia, and whites and African Americans. And this is pretty dramatic, because at the end of the day, this country needs to have a child growth. And I'll kind of emphasize that in a second here. So that growth, particularly Latinos, is really dramatic, to the point that by 2050, when I'm 100 years old, they will outnumber non-Hispanic whites in the country, in the whole country. There'll be 39% Latinos and 38% non-Hispanic whites. That will be America. That will be the U.S. And what does that mean to us? What will the average American look like? And in California, when we think about children in immigrant families, they're clearly not distributed equally. You can look here. Santa Clara County, it's almost 2 out of every 3 children. Los Angeles, similarly. But then we have this dramatic change of different places. But overall, if you look at the major metropolitan areas, those are the children that we have. And here's California versus Silicon Valley. California, 50% of all the kids in California are Latino. More than that are, if you look at the newborns, more than half are Latino. And in Santa Clara County, it's about 40% Latino and 30% Asian, so almost more than 2/3 of every child in Silicon Valley, the most productive place in the world, it's not white. Why does it mean something to us? Why should it mean something to us? These are the population curves, proportion curves of what the population looked like in 1900 versus 20-something out there. And at the 1900s, there were a small proportion of seniors, people like me here, and a large proportion, 40% of the population, kids. So the future was, I could get old and there'd be enough kids there to eventually grow up, be adults, and support me. That has fallen to about 23%. Those that look like me, the baby boomers, it continues to grow up 18%, will probably be 23%. The dynamics of that difference is really problematic for us. It is problematic for Japan. Right now they have one child supporting every 1.5 adult over 65. Now, if you have a tax base, that doesn't work out too well. And in fact, we're at about 0.6. So why kids mean a lot to us now, those of us that are baby boomers? Because they have to be successful. If they're not successful, our tax base goes down, Social Security collapses, and we don't have a nation that's going to be successful. So let me talk about where we are with Latino kids right now. And I'll talk a little bit about the social determinants, healthcare status, effects of acculturation on health, access to cultural competence, and the last one, which I think I want to focus more on at the end here, is really how do we make them productive. So what is health? Health in the past has always been, if you go to a doctor, they give you an antibiotic, you're fine. That's health care, right? Too expensive. We've just gone through Obamacare, and the reason we got there, not because one side or the other wanted to do it, because we had to do it. We were going broke. 18% of everything we produced was going to health care, and that was continuing to skyrocket. We spend twice as much money than any country in the world, and we get worse health care. Nothing dramatic about that. If you put an office up that's to see doctors and make money, or see patients, and the only time they make money is when the patient comes in and you treat them, you want to have them come in more, make more money. That's what made America great, making money. And at the end of the day, that's what happened to us. But now, with the Obamacare and the idea that we have to have so much money, and the healthcare system has to take care of kids, we need to remodel the idea of health. And the Centers for Disease Control has modeled this from data. They have said that if you look at the overall health of somebody, a small proportion of that is from the genetics of the person. What's the risk factor, right? Let me get over here for a second. The genetics, what's the likelihood that you're going to have some disease? The healthcare behaviors, what are you going to do to make that worse or better? The healthcare system, and then this other part, the ecology of how you live. And they have said, if you look at everybody, it's really the ecology of how you live, where you live, stresses and everything else, that makes a difference in whether you're healthy or not. And that has been proven in this country and Europe, and England particularly. They have a curve that goes like this, very linear. The more money you make, the healthier you are overall, the less money, less healthy, and independent of what backgrounds you have. So we have now driven this as the picture for health for most healthcare systems. This is what Kaiser does. And Kaiser got to that first base first. They talked about how keeping people healthy was good profit for them, and it is. They have 40% of the population in California. We just instituted a new program at Stanford to match them, but we're behind the curve. So what we have to deal with now is all these things that we've never dealt with as healthcare providers. Concern about poverty, low education, race, ethnicity, cultural differences, language, the isms, racism. What effect does racism have on somebody? The chronic issue of racism. And being disenfranchised from social institutions. All those things affect people's health. And we as physicians and healthcare providers need to think about that. One of those things that certainly affects kids' health is whether they're an immigrant and whether they're legally here or not legally here. What's remarkable is that we talk about immigrant kids, but as a matter of fact, most of them are U.S. citizens. This group here is all U.S. citizens, 86%. This is a group of parents and U.S. citizen kids, not undocumented parents and U.S. citizens kids, documented kids but not citizens, and only this small proportion are kids that are undocumented. So we talk about immigrant kids, Most of them are U.S. citizens. They deserve to get the kinds of things that we give everybody. Unfortunately, that doesn't always happen for a variety of reasons. The other social determinants that we look at is what's the family structure? What are some of the things that they're living with? As a matter of fact, immigrant kids, as we can see here, live in two-parent families, very high rate, 76%. Here's the overall non-immigrant child, 62%. So they have more intact families. These are the different groups, and you'll see this in the next slides, from Mexico, Central America, South America, Asia, Middle East, other countries here. So if we think about what are the social determinants, one of those is, do you have an intact family or not? Does that help you in health? And I think the answer in most of the literature would be yes. The other is, how well educated are you? Limited English proficiency is another issue. That is, to what degree do you have the skills to navigate different social institutions? And here you see that immigrant children in general, their parents have almost 60% are limited English proficient. But if you look at Mexicans, which again, the biggest proportion is very high. You see the others there. And yet, most of these parents are working. There's this kind of image that people come here to use the services. They come here to work. They always come here to work, and they're working. So at the end of the day, what they've done here is, here's the not native children, 82%, and all the immigrants, very high working. However, they work for very little money. And at the end of the day, if you come with an education that's college or above, you're going to make more money than if you don't. And here we see that natives are 18, and those that are immigrant families, 14, and the lowest is the Mexican Americans. That leads to a situation of poverty, and unfortunately, if we look at both below the poverty line and 200% of the poverty line, we see that immigrants are higher. Among that group, the highest and the largest group are Mexicans. They're almost 2/3 of them at 200% and below the poverty line. The biggest group in California, 50% of all the kids in California are Latino. 60% of that group is immigrant families, and almost 70% of that group is poor. So in summary, this is what I would say are the concerns of the social determinants. Immigrant status, poverty, lower education, limited English proficient. But I think there are buffers here. One is the two-parent family, and also I didn't have it, but multi-generational families, not just two parents, but others, grandparents, etc. And then I think a cultural identity. They know who they are, I think. The question is, how do they fit into this country? So let me touch base then on some sort of overlying healthcare issues that we use to sort of determine population health. First, the major one that we tend to use is infant mortality. How many kids die in the first year of life? Now, traditionally in this country, as you see here, the highest rate of that is for African Americans. It is several times higher than anybody else. And the rationale for that is they're poor. African Americans are poor, so that's why they have higher infant mortality. But Mexican Americans are poor. Mexicans are poor. Here's their infant mortality. Matching or lower than whites. Similarly, another parameter that's used is low birth weight. How many babies are born less than 5.5 pounds? That's a measure of sort of maternal health. And again, African Americans are the highest. And by the idea that poverty induces poor health, we would see that in Latinos. We don't see that in Latinos. They're right here. They're among the lowest. So this tells us that our thinking about healthcare doesn't really match up with some other things that are happening. It matches up with people that have been here. If you look at non-immigrant Latinos, they look like this. If you look at Puerto Ricans and African Americans, they look very similar with regard to poverty. So one of the things that we need to understand as a healthcare system for us is, why is that? Why do we have that difference? And I point out one area. Here's a graph that shows the blues are those that are US citizens and natives, and the reds in all these groups are immigrants. Almost everybody that's an immigrant in almost every country does better than the US population here. But I would point out this one here. African Americans here, almost 12%. Those that are born outside the country, 8%. Now, there is no program that we've been able to induce that kind of drop in this case, if it were or low birth weight. So something's happening in culture and the way people view their world that actually has a very positive effect. When we look at things like obesity, though, that is starting to change. That as we look at obesity in first generation, it goes up every generation. They have some degree of protectiveness, but they are as much overweight as anybody else. And here you see the other groups. Now, why that is a concern, because these kids and families tend to be poor, they're going to have more concern about any excess health problems. And one of the excess health problems, if you're obese, is diabetes. So the estimate right now is that those children born in 2000 that are Latino, that are girls, they have a 50% chance in their lifetime to have diabetes. If a third of the population is Latino, and we have rates of 50%, that's a tremendous impact on our healthcare system. And indeed, it's going to be a significant impact on those populations. If we look at things like asthma, they tend to do better, the immigrants. So that's a good sign. Not really clear why, whether that's a reporting issue, but sometimes it's an issue of how they're living and what they're exposed to. The issue of sort of mental health, immigrants tend to do better. They have, in this case, if you look at first generation, less alcohol use, less marijuana use, about the same level of depressions, and a little bit less suicide. So there are some things there that happen to them that are quite different. The only thing that seems to be consistent over the last 30 years that I've looked at it is that however, as physicians, we think they're doing well. The mothers, when you ask them about their kids aren't doing well. So the idea of health is probably different for different cultures. And the action on health, if you think your child's in poor health, what do? Do you nurture more? Do you do other things? So I think one of the interesting things that one needs to do with this as we look at prevention and how we invest in healthcare is how do we understand when people feel like they're ill or not, and what actions do they take on it? The things that I've showed you in terms of the difference has really brought to bear the idea that there's something out there that has gone against the traditional thing about poor health leading to poor, or poverty leading to poor health. And this has brought what's called the immigrant paradox. That the paradox being, if you have poverty, you should have poor health. And this doesn't happen in all populations. So why should that be? There's some issues here raised that perhaps it's cultural behaviors that are positive, that the extended social support, maybe selective migration. I think this has been something that's been pushed a lot, but I think it's probably these two. But more importantly, I think for us is, are we a society that's willing to have more than one culture? Because if we are, then we can benefit from some of the positive things that cultures bring. And I think for a pediatrician, it's the idea, how do we support, should we support acculturation, have their families acculturate the kids, or should we support the idea of enculturation? Teach them about your culture, make it positive, make it reinforcing, make them understand who they are and how they got here, right? Pictures and all that, and that they are valued. And for a child, I think that means a lot. So right now in pediatrics, we're looking at this balance between enculturation and culture, or acculturation. And it's been looked at, one of the groups I served on was the Institute of Medicine's Committee on Acculturation, or rather immigrant kids. And the bottom line of that report after a year or two of work was, for immigrants, becoming Americanized is bad for their health. So if we don't Americanize them, they stay healthier. A massive literature review by Lara found the same thing. Basically, while you get acculturated, you get better access, maybe feel better about your care, you perceive less poor health, The negative things is you act worse and you get sicker. You drink more, you smoke more, you eat wrong, etc. So I think it's a very fascinating thing for the healthcare system to start understanding, because at the end of the day, we can only get so much money. We're going to have to make people healthy. And again, the Institute of Medicine has said, this is what we need to do. We need to enhance our communication with patients. We need to talk to them in their language. We need to educate them, and we need to sort of develop cross-cultural training for our professionals. And while pediatrics is responding to that in that work, we have something called Bright Futures, and we're trying to make this part of the practice with all these things that were just spoken of in terms of powering families, linguistic care. The matter of fact is, when you look at pediatrics, only 5% of all the pediatricians are Latino. Only 5% are African Americans. And I can tell you in training for the last 30 years, many of our trainees don't speak Spanish, even though they're going to practice in California. And they're not all that culturally well trained. So our challenge is how to make that change, because pediatrics is going to be important. We're the only social institution that gets the kids in the first 5 years. So we have the responsibility and the ability, hopefully, to make a difference. Now, in the past, one of the problems has been insurance. If you're poor, you don't have work, you don't have insurance. The Obamacare will change that for many, many kids. In fact, probably the group in this country that have the most effect are Latinos. And part of the reason is this. This is employer insurance, and whether you're working or not, and this is not having insurance. If you look at Mexican immigrants, they were working, but they were not getting any employer insurance. When you work on a farm worker, if you work day laborers, if you work any place, they're not going to pay your insurance. You get poor wages, you get no health insurance, and then you end up with basically not being insured. That's going to change, and it will hopefully change more rapidly for kids. But I think the adults and the parents are also an important part of this. So, in essence, what I've shown is there's a dramatic demographic shift. We understand that the issues of social determinants of health are going to be more and more important. We have some idea about culture and acculturation and how that maybe helps or not helps the idea of positive health. But we as pediatricians are going to have to deal with a reality, demographic shift, linguistic increasing issues. How do we prevent things from going wrong? But at the end of the day, all the money that's invested in healthcare has to have some positive output. And that positive output has to have productive citizens. Why spend 18% of your GNP if you get kids that come out that can't read or write, don't know how to do math? Right? The investment has to mean something. Most countries think about it that way. We have never thought about it that way. So what is that kind of investment? Well, the unfortunate thing in California, we're a really productive state. There's a lot of talk about how the economy is growing. It's growing well if you have an educated person. Not so well. This is the population, and this is employment demand. High school. Less than high school, college, some college, right? And the jobs are likewise, most in the service, less education. And in fact, not so rosy for even those that go to college, in that this is the low wages workers. And you see that over time, even those in college are going into these kinds of low wage situations. Now, to me as a pediatrician, I'm happy the kids are healthy. But if they don't graduate, if they don't do well in school, it makes me sad. Because I know for the rest of their life, they're going to be in poverty. For the rest of their life, they're not going to do well. But it makes me sadder than the fact that in the day, we have lost that human capital, right? Every child has the possibility to be a doctor. My picture there at the beginning, who would have known that I would have been a professor at Stanford? And, when I look at over the 30 years of all the students I've seen, that's the human capital that I see coming through. So the challenge we have, not just healthcare, but people in education particularly, and others, is how to turn this around. Here's the performance right now of Latino, mostly Mexican children, immigrant families, but it's also Latinos in general. Here is less than ninth grade, a little less than high school graduation. Here's college. So this group doesn't have a rosy picture for the future. Half of the kids of California do not have a rosy picture. And in fact, recently the Hispanic Foundation of Silicon Valley did this assessment of kids in Silicon Valley. We got a C, and the C came from this. Latino children that enter kindergarten are increasing and ready to learn, but by the level of third grade, they're not doing well. 1 out of every 3 Latino students are at grade level at third grade reading and 8th grade, but these numbers are gradually improving there. So basically, it's you look at all these, particularly as a quarter of Latino students drop out of school. We're really not doing what we should be doing. The healthcare investment, 18% of GNP, the educational investment, whatever that is, and we're still getting this product. If you were producing cars, this would be producing cars like that, Yugos, right? You could sell it, but it wouldn't run too far. And I think that is sort of kind of sad. We need to think about kids better than cars and make this happen. There have been studies on this, and clearly large focus from our college and education. That controlling SES and English skills, interestingly enough, once you control those, there is an immigrant paradox in education. Immigrant kids do better in school than non-immigrants. So why is that? Bilingualism and strong family ties, they think, help explain this. But preschool and English proficiency by third grade are critical for Mexican and Latino immigrants for the academic success. So think about it. By third grade, they can determine the rest of their lives. And the issue here, like the end of one of our colleagues, is that low parental education and not English speaking, or not speaking English in the home is associated with poor scholastic outcomes. Failure to master English undermines scholastic achievement, educational attainment, economic mobility. So I think, it's clear that we need to do more very early. And one of the things that I'm doing right now is looking at the national, or really the state data. And we have a state data called the Children's Health Interview Survey. And that basically allows us to look at a lot of the kids in California. So we were interested in what can we as pediatricians do. One of the things we do is encourage people to do educational things with their kids. One of those is reading. And we asked the question, how many parents read to their kid out loud from 0 to 5? And we wanted to know, is there a difference among all these groups? Well, unfortunately there is. And I'll walk you down this list. If you look at reading every day versus never reading, quite significant differences. Less than a high school education, 46%. More than high school, 71%. Poverty makes it go down. Here's non-Hispanic whites, African Americans, Asians, Latinos. But if you look at the difference between immigrant kids and non-immigrant kids, a significant decrease. Whether there's any English spoken in the household, those that don't speak English in the household, a significant decrease. So there's opportunity here to do better. And my hope is I, as a pediatrician, can start linking with my colleagues in education to make a difference. As I said, the educators get the kids at 4 or 5. I get them when they come out. And the opportunity to do something is there. But I think it has to mean something for everybody. If it just means something for those of us that have always been there, not going to happen. So I think the issue here is, how do we spread the message? How do we spread the message that something can be done? Now, luckily we live in a place that message is received really well. There's something called Children's Bill of Rights in Youth. And if you read these, it's very positive, very reinforcing the idea that we value every kid. This was developed by community groups in Santa Clara County. And the group I work with, Kids in Common, leads this effort, bringing all the nonprofits together and making an effort to do positive things for kids and families. And one of that was they decided no kid in Santa Clara County would not have insurance, whether you're legal or not legal. So they got Healthy Kids going. And that then spread to San Mateo County, San Francisco, et cetera. So they led the way. And they continue to lead the way, which I think says to me, well, you know what? I should look out into the community and see who's out there doing new things and bring my skills and talents to help them. And they help me. So as I look at this, I think that the way we're going to approach this and need to approach this, and not just by the academics doing the research, by having these partnerships with communities and groups that have this reinforcement. And if we want to have something change in Congress, they're not going to listen to us. They'll listen to the people that are going to vote. So let me just end that by saying, you know, we have this past, we have this history that we read in our books. We need to learn. Some of us have had those personal experiences. We need to remember. And I think at the end of the day, there is tremendous potential in all the kids that I see, that you see, because every child I look, and they look like I looked. And they look like some kid that could grow up to be a professor at Stanford.